left ear, but they weren't able to do the right ear, and they had scheduled a repeat appointment so they could attempt again. In that time, the patient found myself. It is in my playlist. I'm gonna see if I can tell you which video number it is. So I have previously, I have the original video actually. It took about 45 minutes, I believe, for me to remove the keratosis obturans from the patient's right ear. So since then, the patient's coming more regularly. We're keeping on top of it, and recommending the patient use softening drops on a weekly basis to help keep this at bay, or at least keep the skin plugs a bit softer and easier for me to remove. We're just in the left ear at the moment, and I've used a bit of suction. I'm just using a bit St. Bart's ear hook now, trying to detach the skin from the anterior canal wall. Whilst you're watching that, I'm just going to explain to any new viewers what keratosis obturans is, so you've got an understanding of the condition the patient's got, the cause of it, and the severity, and how it can be challenging to remove. So everyone's ear canals and the outer layer of the eardrum. So remember, the eardrum is composed of 3 membranes. The most lateral membrane, so when we say lateral, mean the one that's facing us, is lined of the same skin that lines the ear canal. The middle membrane of the eardrum is a fibrous connective tissue layer, which gives the eardrum its rigidity and strength. And the medial layer, so the innermost layer that's not visible to us, is a mucosa layer. So the mucosa is the same skin that lines the inside of your nose and mouth. And so in everyone's ears, as I said, there's skin that lines the ear canal and the eardrum. As this skin dies and sheds, it migrates sideways out of the ear. And the ear has the unique property of doing that, enabling that. Over millennia, we've evolved, so the skin that lines the ear canal, as it sheds, it migrates sideways like a conveyor belt. If it didn't, then everyone's ears would be blocked full of dead skin, i.e. just like this patient. So what's happened with this patient is, for some reason, we just don't know the cause, although I've got a few ideas as to why, and I'll share that in a moment once I've removed the skin out of the ear. So in this patient, the skin is dying, but it's not, and as it's shedding, it's not migrating. So it's remaining in the ear. Then you get another layer of skin, and then another layer, and another layer. And eventually you've got multiple layers of dead skin. It's almost like a millefeuille if you're into your pastries, 1,000 layers of pastries, and it's similar to this plug of skin. There's so many layers of dead skin that's combined and stuck together, and this then forms a plug of dead skin, and it was very much like rubber. It's very elastic. As I'm removing this, there's a lot of kinetic energy. It's springy, it's bouncy, and this plug of dead skin expands, and it gets wider and wider and bigger in the ear, to the point where it can completely block the ear canal, and it can cause severe expansion of the ear canal, which this patient does have, and I'll come back to that in a moment. And it can be very, very painful. Now, with this patient, I suspect she's previously had a cholesteatoma, because the attic region, the top part of the eardrum, the bony part there is missing, and we call that an atticotomy. So when you've got a retracted eardrum, so when the eardrum is sucked in like you're on an aeroplane due to eustachian tube dysfunction, the skin at the top, the membrane, the eardrum, you can see the top part of the bones there is missing, and you can actually see the top part of the hammer bone, the neck of the hammer bone. So when you've got a retraction pocket, so when the eardrum is sucked in, and normally it's sucked in at the top, it creates a pocket. So that dead skin that normally sheds and migrates gets collected in the retraction pocket. That then leads to a cholesteatoma. So a cholesteatoma is when you've got a collection of dead skin, and it's trapped in the retraction pocket at the top, and it gets infected. And then this grows inwards and upwards towards the brain, and it can be life-threatening in the worst-case scenarios if it's not treated. So it's very obvious that in the past, this patient has had a cholesteatoma, because they've got the eardrum sucked in, it's created a retraction pocket, and you've got a cholesteatoma there. The cholesteatoma is possibly what's diseased that bone and caused it to die, and so it's no longer there. And when you've got a cholesteatoma, you get discharge, and this discharge trickles from the top part of the eardrum to the base of the eardrum, which then creates a crater. You can see at the bottom is a massive crater. near the eardrum. Now that could be due to the keratosis obturans, a skin plug that's expanding and widening, but for me that seems like it would have been the discharge dropping from the top part of the eardrum due to the cholesteatoma, which has then landed at the base of the ear canal near the eardrum, and it's eroded it, it's diseased it, which is then creates a crater, and then this skin, as it's migrating outwards from the eardrum, it's getting trapped in that crater, thus leading to keratosis obturans. So that's what I feel is the cause behind this patient's keratosis obturans, based on the evidence that's before us. So we've cleared this skin plug, and I'm just trying to remove any layers of skin that's coating the canal wall, because this is not going to migrate by itself anymore. But conversely, it could be that that crater is caused by the keratosis obturans. It's what came first, the chicken or the egg. It's a difficult one to be 100% sure, but we know she's had a cholesteatoma in the past because of the appearance of her eardrum. So we've cleared that ear. Now the eardrum was a bit inflamed and it was retracted still. So we did a pressure test and we measured the air pressure either side of the eardrum. And she has less air pressure behind her eardrum in the middle ear compared to the atmosphere. We call that negative middle ear pressure. And that's caused due to a blocked eustachian tube. So behind the eardrum, we have what we call the middle ear cavity. The air pressure in the middle ear cavity should be equal to the air pressure in the atmosphere. And what regulates the air pressure is a little tube that is connected the middle ear to the back of the nose. We call that the eustachian tube. If you imagine you're on an aeroplane, as you descend on the plane, the air pressure in the plane is greater than the air pressure behind your eardrum. So it forces your eardrum inwards and you feel blocked. And if you've got a functioning eustachian tube, you just close your mouth, pinch your nose and blow. You force air up your nose, up the eustachian tube to pop the eardrum back out. So you equalise the air pressure. But in some people, that eustachian tube is permanently blocked, and which therefore means there's no air in the middle ear cavity. The air gets sucked in by neighbouring cells, and it creates a vacuum effect and your eardrum gets sucked in. And that's called eustachian tube dysfunction. And that's where you can then develop glue ear, because if that eustachian tube doesn't unblock itself, fluid that will normally drain out of it in the middle ear will collect in the middle ear because the eustachian tube is blocked, and you can get a retraction pocket at the top of the eardrum, a formation of cholesteatoma. So a lot of middle ear diseases is due to eustachian tube dysfunction. So we're just in the right ear now. The right ear also, the patient has keratosis obturans, but it's a bit more trickier in this ear because her ear canal entrance is a lot narrower than her left ear. And that's possibly why in the past the patients had problems having this removed at the hospital. So, but nonetheless, it didn't take us too long. We managed to remove this pretty without much difficulty on this occasion, because they have been using drops. They're following their maintenance plan. We're asking them to attend every 18 months to 2 years, which they are, and they're using drops on a regular basis to keep the skin soft. Sometimes the skin can get rock hard, and it makes it much more difficult. So we're just near the entrance in. I'm just trying to wriggle this skin through. We've used some forceps, we've used some hook as well. So using the full range of instrumentation. Similarly to the left ear, it's very spongy, it's very elastic. And what I'm trying to do, because the entrance of the ear canal is a bit narrow, I'm trying to stretch open the entrance of the ear. We're using the endoscope to make it bigger, which then enables me to remove the plugs out of the ear. And you can see there's a big plug here that's just getting trapped near the entrance. But slowly but surely we're wriggling this through. There's a good old tussle there between myself and this plug of skin. So if you were beside this patient, you would be able to see this hanging out of her ear canal, because that's the location we're at. So we're not actually in the ear anymore. The endoscope at least is not in the ear. And this plug would be visible externally. So I'm just stretching the ear back open, just using a hook, just to separate the skin from the canal wall a bit. So I've not used the hook per se to remove the skin plug, but just to loosen it. And I'm just going back in now with some forceps. And when the skin is a bit softer, forceps sometimes are not that effective because it just slices the dead skin instead of extracting the plug out, because the skin doesn't hold itself because it is a bit damper and softer. The forceps almost acts as scissors and it cuts through. So for that reason, just going back in with microsuction, and we're just going to peel this away. And if you stay tuned, you'll see some close-ups of the skin plugs, both all the contents on the tissue, and also zoomed in images of the 2 large plugs that are removed. You can just see how springy, it's almost like a coil. It's got so much, when you let go of the suction probe, it kind of bounces back into the ear. This plug of skin does. And again, we're not actually in the ear at the moment. This plug would be visible externally. And we're just trying to wriggle it through the narrow entrance. So it is putting up a good fight, but we are winning. Almost there. And sometimes with skin plugs, it's best just to remove in one whole piece if possible, as opposed to strands. When you've got, sometimes with keratosis obturans, you're removing this and you're getting layers, individual layers of skin being removed. So if you can try to hold its shape, you can see I'm just going a bit deeper in the ear just to bring the medial end of this plug out. So we're keeping it in its shape, and it's almost out now. There we are. It's a huge plug. So that's the patient's eardrum. So this skin, I think it was attached to the eardrum. You can see there's a bit of a sore spot bottom right. The eardrum is retracted at the top. There is a widening, you can see at the base of the eardrum. So I call that the annulus region, or the inferior recess. That is a bit widened. Again, that could be due to the keratosis obturans expanding the ear. It could have been due to a past cholesteatoma and discharge collecting at the basin of the eardrum, which eroding it. So we've just got a video reel here, just me going over the contents. This is a still image of all